AJOG presents Management of Clinical Choreoamnionitis, an evidence-based approach. Clinical choreoamnionitis is the most common infection-related complication in labor and delivery units worldwide, affecting 1 to 6% of pregnancies in the United States. The objective of this expert review was to examine and summarize the existing evidence regarding interventions proposed for the treatment of clinical choreoamnionitis. Treatment should be initiated during labor rather than in the postpartum period. The first-line antimicrobial regimen of choice is ampicillin combined with gentamicin or ampicillin-sulbactam. Patients undergoing cesarean delivery could benefit from receiving clindamycin at the time of umbilical cord clamping. After delivery, there is no evidence that additional doses of antibiotic therapy are required to reduce short-term morbidity. However, if post-delivery antibiotics are prescribed, one additional dose appears to be sufficient. Acetaminophen can be administered orally or intravenously to reduce an elevated maternal temperature. Observational studies suggest that this may result in a decreased fetal heart rate in cases of tachycardia. The administration of at least one single dose of betamethasone or dexamethasone to induce fetal lung maturity and of magnesium sulfate for fetal neuroprotection to patients with clinical choreoamnionitis between 24 and 33.67 weeks of gestation and possibly between 23 and 23.67 weeks, has an overall beneficial effect on the infant. However, delivery should not be delayed to complete the full course of corticosteroids and magnesium sulfate. Once the diagnosis of clinical choreoamnionitis has been established, delivery should be considered regardless of the gestational age. Unless contraindicated, induction and trial of labor can be considered. Patients may require a higher dose of oxytocin to achieve adequate uterine activity. Vaginal delivery is the safer option, and cesarean delivery should be reserved for standard obstetrical indications. Continuous electronic fetal heart rate monitoring is generally recommended, although there is no clear evidence of its benefits. The following approach summarizes interventions in patients with clinical choreoamnionitis according to gestational age at diagnosis.